Hello, my name is Adam Furst, and I'm happy to present this poster summarizing an observational study of the association between parathyroidectomy and stage 4 or worse chronic kidney disease in patients with primary hyperparathyroidism, which I will refer to as PHPT. PHPT is a common endocrine disorder that, when untreated, is associated with morbidity primarily related to the bones and kidneys. Multidisciplinary guidelines currently recommend parathyroidectomy to slow the progression of chronic kidney disease among patients with PHPT who also have an estimated glomerular filtration rate, or eGFR, below 60. However, the guidelines are based on small studies and limited data. To better understand the association between parathyroidectomy and chronic kidney disease, we performed a longitudinal cohort study of patients within the Veteran Health Administration over a 20-year period. PHPT was biochemically diagnosed based on having a parathyroid hormone level above 65 within 3 months of a serum calcium above 10.3. Caution was taken to exclude patients with tertiary hyperparathyroidism based on end-stage kidney disease or transplant or receiving dialysis. We used the updated eGFR calculation based on the CKD epi equation that does not include race. Based on clinical relevance and the consensus guidelines, we stratified our cohort by eGFR less than or greater than 60, assessed within 1 year prior to surgery, referred to as the baseline eGFR. The parathyroidectomy group included patients who received surgery within 2 years of PHPT diagnosis. Patients who received delayed parathyroidectomy were included in the control group for the primary analysis and excluded for sensitivity analysis. Patients in the control group were assigned a random treatment date to simulate the time elapsed between diagnosis and surgery. Additional covariates were assessed to adjust for patient demographics, such as age and race, comorbidities, such as BMI and the Charlson-Deyo Comorbidity Index, as well as history of stroke or coronary artery disease, and the severity of PHPT, such as serum calcium or kidney stone history. The outcome event was stage 4 or worse chronic kidney disease. This was defined as having at least 2 eGFR measurements below 30 that are at least 3 months apart. We further required that the eGFR must drop by at least 15 to avoid identifying minor fluctuations in eGFR. For a main analysis, we performed an inverse probability of treatment weighted Cox proportional hazards regression to calculate the hazard ratio between the surgical and the non-operative management groups. The high and low eGFR strata were analyzed separately, including separate propensity models. To implement the Cox model, we censored patients on the date of their last serum creatinine measurement, which was used to calculate the last observed eGFR, that was within the study period. We applied doubly robust adjustment, whereby all covariates used to estimate the propensity scores were included in the weighted Cox model for adjustment. Our results showed a significant protective effect of parathyroidectomy against developing chronic kidney disease in the high eGFR group of patients who had a pre-treatment eGFR above 60. The hazard ratio for this group was 0.6, with a statistically significant confidence interval. However, parathyroidectomy did not offer the same protection to patients in the group having a pre-treatment eGFR below 60. The hazard ratio in this group was 0.99. Further investigation with an interaction plot, as you see on the right upper portion of the poster, showed that parathyroidectomy appeared to be associated with a lower risk of progression to stage 4 or worse chronic kidney disease for patients with higher eGFRs, with statistically significant confidence intervals from eGFRs around 60 to 85, which may well be related to the relative number of patients with eGFRs within this range. In conclusion, we found that in this observational cohort study, parathyroidectomy was associated with a decreased risk of progression from near normal kidney function to stage 4 or worse chronic kidney disease. While we are hesitant to draw conclusions in the low eGFR group due to the smaller sample size, we do believe that guidelines discouraging parathyroidectomy in patients with high eGFR should be reconsidered based on these findings. I would like to thank you for your time, and I would also like to thank my co-authors, especially Drs. Saib and Tricky, for their mentorship. If you would like to contact me with any questions, my email address is in the bottom left-hand corner of this poster. Feel free to contact me at any time. Thank you again for your time.